And I can let you all know that we will be recording this webinar, and the recording as well as the slides will be sent out following the webinar today. So next slide. I want to thank you all so much for being here for our Take Action Menopause. My name is Deborah Friedman. I'm Assistant Commissioner for Workforce Engagement and Innovation at the Mayor's Office of Labor Relations. And it is our pleasure as WorkWell to sponsor this webinar for all of you today. In case you don't know about WorkWell, and hopefully there's nobody here who doesn't, I will just remind you that WorkWell is the worksite wellness program for City of New York employees. We are here to take care of you while you are busy taking care of all of the people who find themselves in New York. And we really appreciate the work you do. And we work in multiple, what we call bucket areas, focusing on Move More, physical fitness, our stepping challenges, our digital fitness classes, in-person fitness classes, a whole range of programs. Our healthy eating in our Eat Well program, where we have cooking demonstrations, nutritional counseling. We have a 5-a-day program where we encourage people to eat fruits and vegetables, just helping all of us understand how we can eat better. Our Take Action, which is all about prevention and protection of our health. Some of you participated, or many of you hopefully participated in our recent flu campaign, where we had vaccine clinics at over 150 city work sites and many other programs, including Take the Sugar Down, which is happening right now as we speak on another channel. We also have our Be Well program, which helps to support the mental health of all of us. It's a stressful time and a stressful world, and we know that we need to build our resilience through things like meditation, gratitude, resilience building, and yoga and other ways. And then finally, our Project Build, which is our health equity lens. We recognize that health is very much based on identities and our access to care. And so we want to make sure that everything we do is inclusive and is accessible by all. We have one of the most diverse cities and one of the most diverse workforces, and we want to make sure everyone is included and at the table. So that's WorkWell. Next is why we're here today, to talk about menopause. Well, one of the things that's really was the trigger was Mayor Adams earlier this year talked about wanting to make the workplace healthier for women and female identified people. And we rose to the occasion. A few months ago, or last month, I guess, we had a breast cancer awareness, not only for women, female identified, but all people who need it. We also recognize that menopause is going to affect at least 58% of our workforce. And finally, we know that menopause isn't really well understood. With 58% of us going through this process, many of us never really learned about what's happening to our bodies or to our colleagues' bodies or family members. And so we're going to be here to hopefully dispel some of the myths and provide some new truths. So what is our agenda for today? We're going to be starting with what is menopause, as I just said, and then how do you manage and treat it? And finally, how do you manage it in the workplace? What are opportunities available for you? And as I said earlier, we are recording this session, and we will be sending out the recording and the slides following the session. In addition, if you have questions, please put them in the Q&A so that this way all can see your questions, and we'll save the chat for other feedback similar to what we've done so far, like what should be the theme song for this work. So you can keep that going, and we'll collect it for a song list later. And so put your Q&A questions in that feature. We'll have a Q&A session at the end of the presentations. So now I want to introduce you to our extraordinary panelists. We have Dr. Amita Murthy, who is a city medical specialist within the Bureau of Maternal, Infant, and Reproductive Health at the New York City Department of Health and Mental Hygiene. Prior to working at DOHMH, she held positions director positions in a New York area Planned Parenthood affiliate, as well as within the Department of Obstetrics and Gynecology at 2 major academic centers. After receiving her medical degree at SUNY Downstate, Dr. Murthy completed her residency in OBGYN at BU in Boston. She then went on to complete her fellowship in family planning and clinical care research at the University of Pittsburgh. Dr. Murthy is a board-certified OBGYN with experience treating patients in a variety of settings with a range of socioeconomic backgrounds, including patients from resource-poor urban areas, as well as those with more privileged backgrounds. Her role at the health department, as well as her clinical expertise, has provided her the ability to be a voice in New York City, particularly for those who are underinsured or underserved, or suffer from disparities in care. As an educator for both patients and medical trainees, she manages to break down large, complex concepts into easily digestible chunks that are evidence-based and complete, and you will see evidence of that today. She also has experience public speaking, focused on presenting and reviewing data, as well as its clinical application. All of her work is informed with a reproductive justice and equity lens. Her specific interest in family planning include issues surrounding obesity and efficacy of contraception, intrauterine device insertion, and timing related to completion of pregnancy, as well as reproductive health of immigrants. Welcome, Dr. Murthy. And then next we have Melissa O'Neill, who is the Director of Investigations and the Compliance Unit in the Citywide Equity and Inclusion at DCAS, Department of Citywide Administrative Services, where she provides guidance to the city's agency EEO officers on the application of EEO policy, oversees EEO investigations involving agency heads or EEO officers, develops training for agency-level EEO professionals, as well as workforce compliance training. Melissa is a skilled EEO and employment law attorney with substantial experience overseeing and conducting complex investigations, issue identification, fact-finding and analysis, problem-solving, and devising and implementing compliance and risk mitigation procedures and strategies. Prior to joining DCAS, Melissa was an assistant attorney general in the New York State Office of the Attorney General's Bureau of Consumer Frauds and Protection, as well as a member and then chair of the Attorney General's EEO committee. Prior to that, Melissa was a litigation associate at Patterson, Belknap, Webb, and Tyler, LLP, where her practice focused on complex commercial litigation. Melissa also served as a law clerk to the Honorable Joan Azraq and the Honorable Nina Gershon in the U.S. District Court for the Eastern District of New York. Melissa earned her degree from New York Law School and her bachelor's from Lehman College. Welcome, Melissa. So as you see, we have extraordinary talent here working for the city of New York and able to educate all of us on this topic. So with that, we want to find out what's going on for you. So this is the first poll, and you'll see a series of these over the course of the session. And also I should say Heidi Bear, a WorkWell Citywide Wellness Coordinator, is in the background making the magic happen on your screen. So thank you very much, Heidi. Heidi just pulled up the poll, and the question is, how comfortable are you talking about menopause in the workplace? 1, not at all comfortable. 2, slightly. 3, somewhat. 4, fairly. 5, completely comfortable. All right, let's give folks a few more minutes. We have about 70% participation. All right, let's give it a moment. All right, let's take a look at the results. Wow, it's all over the map. It's like 24% of you feel completely comfortable talking about it, and then it's almost 20% in every other section. I know that's not right mathematically, but you get it. So thank you for sharing. So we're hoping that by the end of today, you will come away feeling a little bit more comfortable and confident talking about and understanding menopause. So with that, I'd like to turn it over to Dr. Murthy to help educate us. What is menopause?
Good afternoon, everyone. I'm so excited to be here and to talk about menopause, talking about women's health, and reviewing all aspects of women's health is something that I find incredibly satisfying and really something that I live and enjoy doing. So let's talk about what menopause might be. Menopause is a retrospective diagnosis. What does that mean? It means that you actually have to not have any menses. These are naturally occurring menses, not those from birth control pills or from hormonal treatment, but naturally occurring menses for 1 year. So the other um, caveat to that is that this is also not as a result of chemotherapy or surgery. When a woman does receive chemotherapy or surgery, that has different connotations and will have different levels of risk of development of later disease, particularly cardiac disease. So, again, just as a reminder, natural cessation of menses, and it's a retrospective diagnosis. So, next slide. What does that actually mean to get to menopause? In the United States, the average age of menopause is 51. However, that may be different across different races and ethnicities, and there's a wide range. Ideally, it can start from as young as 45 and can last as up to late 50s. So, that time period before you get to that 1 year of ending natural menses is really called perimenopause. And as I'm saying here, they can last anywhere between 5 to 10 years. Next slide. So, what are some common symptoms? Some physical symptoms include vasomotor symptoms. That's the fancy medical degree term for your hot flashes, your abrupt changes in temperatures, your night sweats. You may have changes in urination. You may also have changes in your vaginal vulvar milieu. What does that mean? That means that you may experience such wide ranging symptoms like dryness or irritation or vulvar atrophy. Those are the most common things. This is evidence of the lack of the ovaries producing estrogen. And what estrogen does for us during our normal cycles is to cause the vaginal milieu to be lush and bountiful. What do I mean? It's well lubricated, it looks very pink, and it is receptive to both intercourse as well as pregnancy. So I'm going to address some of the questions that I'm seeing here. Um, and so the first question is, if you do take some form of HRT or birth control to regulate your menstrual cycle, would that mask your menopause? And how do you know when to transition off those meds, if at all? So yes, taking medications can mask your transition to menopause. And generally, when you speak with your women's healthcare clinician, at or around the age of 50, there should be some discussion of either transitioning off those medications or moving to some other form of those medications. And so this is really a discussion that you need to have with your clinician and really talk about what the benefits were for you to receive that treatment earlier on and what would be the benefits and risks of continuing. Are yeast infections or bacterial vaginosis signs of oncoming menopause or premenopause? So, no, I'm not going to say that infections are signs of oncoming menopause or premenopause. What I will say is that if you do have one of those infections, being perimenopausal or menopausal will make your symptoms much more uncomfortable. You may find that your symptoms of itching or discharge are much more irritating, and you may be seeking help further on. The presence of getting those infections is not due to necessarily the onset of perimenopause or menopause. Both of those infections indicate a change in the bacterial balance within the vagina. Can that be affected by menopause or perimenopause? Usually, no. But if perimenopause or menopause is complicated by another medical problem, like diabetes or other medications, then yes, your symptoms may be worse than before. So let's talk about some other common symptoms, which include changes in breasts. You may feel more pain or more tenderness, or you may feel more lumps and bumps. Next slide, please. Other common symptoms include hair loss, joint pains, changes in weight, and changes in the distribution of that weight. So you may notice, whereas before, if you were gaining weight, you may have noticed it in one area, suddenly you'll notice it in a different area. You'll definitely see menstrual changes, either in regularity, i.e., you won't be getting them monthly. You may see shorter cycle lengths, which is the time between each period. You may see changes in the length of that period, as well as the amount of the flow. And you may have trouble sleeping. This is often associated with the hot flashes and night sweats, but there may be other reasons causing that trouble sleeping as well. Some other, we'll go to the next slide. Some other symptoms include some psychological and emotional symptoms, and that could be a sense of decreased libido, trouble concentrating, brain fog, as well as more anxiety, irritability, or symptoms of depression. You want to be sure that you definitely see your clinician and talk about these symptoms and get screened for an actual diagnosis of a mental health disorder if that might be there. Next slide. So other symptoms and other things that we'll look for include metabolic changes. And this is where the risk of later disease and development of other disease comes in. So you'll definitely see changes in your cholesterol. You may see an increased rate of heart disease because estrogen is considered a protective hormone against heart disease for women. As we age, we are more risk of developing diabetes, which is high levels of sugar in the blood, as well as changes in our bone density, both osteopenia and osteoporosis. You know that we all live, next slide, we all live in the area of New York and we're all chronically vitamin D deficient, but menopause will exacerbate that. So what are our treatment options? We talked a little bit about all of the symptoms. And so your first treatment option really is medication. And what does that include? Really depending on the strength and intensity of your symptoms, we have both hormonal therapies as well as non-hormonal therapies. Your hormonal therapies really are the replacement of estrogen or progesterone. The formulas that we have now are safer, as well as we have more delivery options. So as before, if anyone remembers the Women's Health Study in 2002 that was stopped, we mostly only had pills with one kind of estrogen that was synthetic. We now have other kinds of estrogens that are either plant derived or not, or synthetic, but with different, slightly different activities and definitely different chemical structures. And we have more ways of delivering it. So now we have not just tablets and pills, but we have patches and we have rings and we have vaginal creams and vaginal tablets. We have combinations of pills that have both hormones and bone protecting properties. So the hormonal therapies will really depend on what your symptoms are, what's really bothering you, and a discussion with your clinician about what delivery mechanism would work best. If you want to focus on your non-hormonal therapies, there are many different kinds of things. So biosimilars would be the things that have estrogen-like products. So you may have heard of things like soy, black cohosh, some other things. So those are your biosimilars. They come in various deliveries mechanisms as well, whether they be tablets that you can buy over the counter or teas or other creams and supplements. You have different herbs. We had somebody talking about sage tea in the question and answer. And there are other different herbs as well. Black cohosh is sort of in that family. And there's another one whose name I'm completely blanking on at this moment. So the gels can both be hormonal as well as non-hormonal. Some of the herbs and other biosimilars can come in gel format, but the hormonal portion of the gels would be, some people include testosterone in there. So testosterone delivery might be in the form of a gel. And you may use an estrogen patch and a testosterone gel. So there may be a mixture of delivery mechanisms. And finally, for those women who may have contraindications or be unable to take a hormone or just don't want any hormones at all, SSRIs, or selective serotonin reuptake inhibitors, which are commonly used to treat depression, there's a class of medications that actually are very effective in treating your vasomotor symptoms. Um, they work very well for hot flashes and the night sweats, not in the same strength dosages as used for depression, but definitely a class of medication that can be used for treatment. And so don't be alarmed if someone starts talking, if your clinician starts talking about, for example, Effexor or another form of medication that you may have heard is being used to treat depression when talking about hot flashes, because this is a viable option. Next slide. So let's talk about some non-medical options or complementary options, which include meditation and acupuncture. Some women have had great success with acupuncture and acupressure in assisting with some of the emotional symptoms as well as some of the physical symptoms. There's always cognitive behavioral therapy and diet and exercise, including yoga or whatever exercise you normally do to keep yourself in shape. Next slide. All right, so we have a poll, and the question is, Sonia has frequent trips to the bathroom as a symptoms of her menopause. Can Sonia ask her EEO officer for an accommodation? The answer options are yes, no, and unsure. I guess you can put it in the chat. Oh, nope, here's the poll. So we'll give it a minute, and as we get close to 200, whenever you want to end the poll, I think we can end it. So most of you have answered yes. I'm going to transition this back to Deb so that we can move on to the second portion of our talk. Thank you so much. And I will be going through some of the questions in the Q&A and answering them, as well as those in the chat.
Great. Thank you so much, Dr. Murthy, for helping us understand what it is. And you'll see there's still lots of questions about side effects, about treatment options, and getting clarity. And thank you for participating in the poll. I think that we are well poised to understand from Melissa what opportunities we have at the workplace. So hopefully when we end, the folks who are unsure will be sure of the answer. All right, take it away, Melissa. Thank you.
Hi, thank you, Deb. So I just want to say hello and good afternoon to everyone. I'm so happy to be here today. I want to thank our partners at Workwell for inviting DCAS to participate in this very important discussion. As stated earlier, my name is Melissa O'Neill, and I am the Director of the Investigations and Compliance Unit in Citywide Equity and Inclusion at DCAS. And I am here today to give you an understanding of the city's reasonable accommodation process and how it may generally apply to conditions arising from menopause. I'm not here to tell you what reasonable accommodation your agency has to give you, because as you're going to see from our discussion and the topics that I present, reasonable accommodations are very fact-specific assessments. They consider many variables, such as the individual's condition, the essential functions of their job, and the operational needs of the agency. So let's start with some notable facts and figures about women and menopause in the workplace. I found this interesting as I was preparing for this presentation. So according to the US Bureau of Labor Statistics, in 2022, women made up 56.8% of the workforce, but women ages 45 to 64 made up more than 17% of the workforce. I also came across a 2023 study by the Mayo Clinic that reported that menopause costs American women an estimated $1.8 billion. in lost working time per year. Roughly 15% of study participants said they had either missed work or cut back on hours because of their menopause symptoms. A little over 1% of study participants said that their symptoms had become so debilitating that they either quit their jobs or were laid off in the preceding 6 months. So here I want to talk about what options might be available given those pretty stark numbers. So first, what is a reasonable accommodation? So reasonable accommodations enable individuals who have needs under certain qualifying bases to perform the essential functions of their job and enjoy the equal employment opportunities. The reasonable accommodation can be anything from a change to the workplace environment, change to a rule or a practice, or a change to an individual's job or operation. And what's important to note is that agencies are required to accommodate all eligible employees to allow them to perform the essential functions of their position unless that accommodation would result in an undue hardship for the agency. So another thing to note is that there really is no one size fits all approach when it comes to reasonable accommodations. The reasonable accommodation process must be flexible, interactive, individualized. There must be meaningful, cooperative, and timely communication between the individual requesting the accommodation and the agency. Next slide, please. I think we went back. Thank you. So, who is eligible for a reasonable accommodation? So there are 4 general categories. First, you have individuals with disabilities. You have those who fall into the category of pregnancy, childbirth, or related medical conditions, which can be things like miscarriage, termination of pregnancy, postpartum depression, lactation needs, etc. Those who have religious needs, and victims of domestic violence, sex offenses, and stalking. So one of the things that I do want to point out is that reasonable accommodations are only for the requester's condition, not the conditions or the needs of another. And where this particularly tends to come up a lot is with caregivers. So for example, caregivers are not eligible for a reasonable accommodation if they are caring for someone who has a disability or might be pregnant. It's for the employee's own condition. So a caregiver could, however, be eligible for something like intermittent FMLA, but not for an accommodation. Finally, the accommodation requested by the employee may not necessarily be the one that is granted by the agency. The agency has to assess and determine which accommodation is the most reasonable without imposing an undue hardship on the agency. Next slide, please. So here we're going to discuss, for the purposes of this presentation, basically the first category, and that is disability. So what is a disability? Now, under the Americans with Disability Act definition, a disability is a person who has a physical or mental impairment that substantially limits one or more of the major life activities, has a record of such impairment, or has been regarding as having such impairment. Now, definition under the New York City human rights law, the disability means simply any physical, medical, mental, or psychological impairment or history or record of such impairment. So this would encompass both your temporary or your short-term injuries as well as chronic conditions. But the important thing to note is that under the New York City human rights law, conditions do not have to substantially limit the individual's major life activities. I think it's also something that I should note is that the New York City human rights law is New York City's anti-discrimination statute. And that is what governs New York City employers, including New York City agencies. It is much broader than the Americans with Disabilities Act. In fact, city human rights law is one of the most broad and remedial anti-discrimination statutes in the country. It's actually designed to foster inclusivity and accessibility so that people with disabilities can enter and remain in the workforce. So under the New York City human rights law, employees experiencing the symptoms of menopause actually might be eligible for a reasonable accommodation. Next slide. So just to review a few basic principles about reasonable accommodation. An employee who needs a reasonable accommodation should submit a request to their agency's EEO office. Every agency has an EEO officer. It is prohibited retaliation for an agency to take adverse action against an employee for requesting a reasonable accommodation. If that should happen, the employee should absolutely file an EEO complaint. Once an employee has submitted the request for the reasonable accommodation, the EEO office will engage in what's called a cooperative dialogue. This is essentially a good faith dialogue between the employee and the EEO office, and they're going to address the employee's accommodation needs, discuss potential accommodations that might be available, the difficulties that the potential accommodations may pose for the agency, and also what alternative accommodations might be available to the employee. The objective of the cooperative dialogue is to determine the appropriate reasonable accommodation that allows the employee to perform the essential functions of their job, but at the same time doesn't create an undue hardship for the agency. There might be an instance during your reasonable accommodation cooperative dialogue discussion that the employee will be asked to provide medical documentation. And that's to give the EEO office a better understanding of the nature, the severity, and the duration of your impairment. What symptoms are you having? What can we do? How is it affecting you? How is it affecting your job performance? What specific accommodations would be helpful in addressing the situation and the need for the accommodation? Next slide. So this is this next point is very important, and I do want to point out there shouldn't be any agreements between a supervisor and an employee concerning an accommodation. The employee still needs to undergo the reasonable accommodation review process through the EEO office. The reason this is so important is so that consistent procedures and documentation, they are essential to the equitable treatment of employees. You don't want to be in a situation where someone who happens to be friendly with their supervisor makes the agreement to have a reasonable accommodation, but someone who may not necessarily have the same relationship with their supervisor does not get the accommodation. So the supervisors also shouldn't be privy to an employee's confidential medical information. The one thing is that the employee, the EEO office can talk to the manager or the supervisor to discuss what the operational impact of the accommodation would be. Also, the EEO office will assess the employee's needs. They will gather all the information. They will make an informed determination on the agency's request. Next slide. So some examples of reasonable accommodations for individuals who are experiencing symptoms of menopause. This is just, again, some examples. There may be many more that you can think of, but modifying work schedules, allowing for additional restroom breaks, allowing for flexible use of leave time, modifying or reducing the worksite temperature, using a fan at the workstation, modifying the dress code, right? So if you normally have to wear a long sleeve shirt as part of your uniform, allowing the employee to wear a short sleeve shirt, redirecting the air conditioning or the heating vents, and providing leave for counseling and or treatments. So here I provided you with links to some resources. The first two deal with the city's reasonable accommodation policies. There's a brochure for city employees that breaks all the categories down and the process. We have reasonable accommodations at a glance, and there is also the job accommodation network, and they provide information about workplace accommodations. I think one of the key takeaways from this entire discussion is that if you're having issues performing the essential functions of your job because of symptoms related to menopause, please do not suffer in silence. There are resources available to you. Talk to your physician about your symptoms and your concerns. Talk to your agency's EEO office about potential reasonable accommodations if you think that one is needed. Thanks.
Thank you so much, Melissa. We really appreciate it. And I know there's a few questions in the chat. So before we move on to our Q&A, we just want to get a sense of the folks in the room. Have any of you or your coworkers made work adjustments to address symptoms at the workplace? Yes, no. And if you can just share what those accommodations were in the website, in the chat section. Thank you. Thank you all for being such good participants. I love it. I see, yes, a fan, lots of fans coming in. So the team here are fans of fans. All right. So it looks like 60% or so have not or are not familiar with anyone having adjustments. About 24% have said yes. So we see lots about fans, having extra clothing and undergarments in the office, leaving work early to go to doctor's appointment, having a sit and stand desk, lots of fans. Okay, yeah, and just as a reminder, we will be sending a follow-up email that will have all of these resources that will have live links, so you don't have to copy it down, not to worry. And it'll also be part of the recording. All right, well, thank you so much. And so now we have questions. So I saw that Dr. Murthy was doing a bunch of typing while Melissa was talking, so thank you for that. And I tried to go through, and I'm going to try and summarize. But actually, maybe Melissa, since you're still on camera, why don't I give you a couple of the questions that came up for you that you might not have seen. Is reasonable accommodation a possibility as an accommodation for symptoms of menopause?
Yes. It's a possibility. It's not a guarantee. It's a possibility. Again, as I stated, it really depends on what your symptoms are, what the essential functions of your position are, the needs of the agency, and whether that accommodation would pose an undue hardship.
Can an accommodation be made for folks coming in late because of fatigue or insomnia?
In certain circumstances, yes. I mean, these are all situations where the employee would need to go to their EEO office, explain the situation and the symptoms that they are having, and if necessary, provide the medical documentation. And if it is not an undue hardship, an accommodation for that, what we're going to call a modified work schedule based on that could work.
And if somebody's not getting a response from their EEO officer, what can they do? What recourse do they have?
What recourse do they have? Well, I should definitely hope that that's not the case. But if they are not receiving a response from their EEO officer, I think there's a couple of things that they can do. They can actually physically go to the EEO office and try to, because usually it's not just their EEO officer, there's staff there. So there could be a deputy EEO office, a reasonable accommodation specialist that way. But also I think that what they could always do is, I will put this out there, is they can contact CEI and say it has been, X number of weeks and I haven't heard anything, and I need some assistance.
So perhaps what we can do is put the contact information for CEI in the follow-up email, so that if somebody, but recognize, folks, it's not for everybody who doesn't like what the accommodation.
No, that is absolutely not what it's for. But if I have not really heard of instances where EEO officers are not getting back, because as you will see from a reasonable accommodation at a glance guideline, there are very strict guidelines in terms of timing, right? So they have to respond to them, to meet with them, to conduct a cooperative dialogue. And at the conclusion of the cooperative dialogue, they have 30 days to issue a written determination. I would be very surprised, in fact, to hear that EEO offices, whether it's the EEO officer, but EEO offices are not getting back to employees at all.
Okay, and I see there was also a question about Health and Hospitals, one of the hospitals, and the DCAS CEI office doesn't have oversight on health and hospitals, so we'd have to find out where the escalation could be at H&H, and we can include that in the file. Okay, so we'll add that in. All right, so Dr. Murthy, there's a ton of questions, as you saw, about different side effects of menopause, but maybe if you can talk a little bit more about some of the treatments. People had questions about what supplements are available for hot flashes, what is the HRT that has bone protection? Is magnesium a supplement that could be included? How about if you can also talk about CBT and THC for that matter, and anything to combat fatigue, in addition to coffee.
Right. So
I'm sorry, if you could put your camera back on, that'd be great. Thank you. There you go.
Sure. Here I am. Hello. Let me first provide the caveat that, all of these answers that I am providing are generic and general answers, and I recommend that if you do have a specific symptom or a specific question, that you reach out to your women's health clinician and make an appointment for further evaluation and discussion. It's really difficult to personalize any information without more context. And more information as to your risk factors and your age and whatever else is going on. So for the first of these questions, let me see. I'm trying to find it.
What if you can speak to supplements?
Oh, supplements and medication. Okay, so again, someone asked about side effects for medication. It would depend on what medication that we're talking about, and would be very specific to not just the medication, but also other interactions it may have to other medications that you're currently taking, as well as supplements that you're taking. Generally, let me talk about, there's a medication called Duavie, which is being marketed for those with hot flashes as well as bone protection. And there's a number of other newer medications that have come out in that family as well, which have that. I cannot tell you if your insurance will cover it, nor can I tell you anything other than the fact that these are new medications and therefore may be expensive, but they are available. Supplements and herbs have a wide range of products, and I generally don't like to recommend anything directly, again, to a general population without knowing the person in front of me. But there's lots of different brands, and they have lots of different mixes, and they have lots of different ingredients and delivery platforms. And so really it is a matter of looking at the supplements, looking at the ingredients, and being sure that most of the herbs that are in there are those that are either bioidentical, that are similar to soy or other plants that have estrogen-like properties, or are herbs in the black cohosh in the yam family that have estrogen-like effects that may help you. Our diets in general, as far as magnesium is concerned, we don't get enough magnesium. And so sure, taking a magnesium supplement may be helpful. Can I say that it will be helpful for your symptoms? No, I can't, but it may be helpful just in general. I believe I answered the question about fatigue. Fatigue in general can be a symptom of many other disorders, including some serious ones. Generally, coffee, exercise, and sleeping better are ways that I can tell you now to improve that sense of fatigue, as well as ensuring that your diet is low in salt and healthy. Sleep hygiene is very, very important. But if your fatigue is debilitating or extreme, you should see your clinician for further evaluation. There may be some other serious disorders that have nothing to do with menopause that are affecting your levels of energy.
There were questions about other side effects, such as itchiness, mood swings and agitation, prolapse, balance,
Right.
joint pain, higher blood pressure, weight gain. Are these all potential signs of menopause or perimenopause?
Depending, thanks, Deb. Depending on your age and what other associated history you may have, yes, they may be signs of perimenopause, but they may also indicate other disorders as well. Again, it's really difficult to generally talk about something without knowing the context. So it's if you actually look in the textbook, the list of possible symptoms and changes that a woman can have when coming into perimenopause is like 40 symptoms long. And so, and unfortunately, there are no specific symptoms other than irregular bleeding, hot flashes, and vaginal dryness that I could say are very specific to menopause. Almost everything else is a symptom that could be indicative of another problem or might be associated with something else. And so it is really something that is a discussion that you need to have with your healthcare clinician, and really talking and discussing what may work best for you.
Can you just explain or define sleep hygiene?
Oh, sure. Sorry about that. So when I talk about sleep hygiene, this is really about ensuring that the sleep that you get is restful and ensures that you are not going to be tired or have poor sleep quality. So usually those recommendations include things like making sure that you eat dinner a minimum of 2 hours before your bedtime. Do not do anything very activating in those 2 hours before you plan on going to bed, like exercise or drinking caffeine. We know that caffeine and alcohol can affect the quality of your sleep, so you want to avoid those products in those 2 to 3 hours before bedtime. And sadly, screen time is a huge thing. Screen time and blue light and watch and the exposure to screens can affect the quality of your sleep. So you don't want to do that. You want to really have this sort of ritual around going to bed that is calming and very much putting your body in the mindset of this is now bedtime and we need to move to bedtime. And so that really includes things like not having screens in your bedroom, and really ensuring that your room is as quiet as possible, that you have a way to block light from coming in, and ensuring that the place where you sleep is as quiet and calm as possible.
Thank you. And actually, I saw one of my colleagues put a link to our sleep webinar that we had a couple of years ago, and we'll put that in the follow-up email where we had one of the sleep specialists from Bellevue talking all about sleep hygiene. So we could take one more question. If you can speak, there's a number of questions about operations, hysterectomies that led to menopause and the impact on potential symptoms and treatment and things like
Sure.
that. So,
I'm sure I'm happy to. And I'll also talk about the one question about the difference between HRT and a low dose pill. So a hysterectomy is the removal of your uterus. It does not mean that your ovaries were removed. So the only symptom that you will have is a cessation of menses because you don't have the physical organ where menstrual blood is created and from where it is released. So it's difficult to talk about if you had a hysterectomy and they did not take out your ovaries and you are, I don't know, 40 when this happened, then you are not in menopause because your ovaries are theoretically still working and still cycling as they normally do. The only thing is that you will not have your period to tell you that that they're working well. So we have to go based on other symptomatology, which would include the things like the vasomotor symptoms, the vulvar vaginal atrophy, maybe some evidence of osteopenia, the change in bone mass, or osteoporosis. And so that is some education that you will have to definitely obtain from your surgeon to ensure that you understand what is remaining in your body, and then how that will change both the symptoms that you experience as well as what your risk of development of later cardiac disease might be. As far as hormone replacement therapy versus low dose estrogen containing birth control pills, really the difference is twofold. In contraception, we have 3 different ways of delivering medication, which is a pill, a patch, or a ring. Right, but for and then the estrogen that's in there is very different than the estrogen that is contained in hormone replacement therapy. And the amount of estrogen contained in a low dose pill versus what's in a hormone replacement therapy medication is almost tenfold difference. And so the purposes for the medication are very different. And so those are some basic facts. Things change more when we talk about what kind of estrogen and what delivery platform and all sorts of other things.
Great, thank you. And I just wanted to say, I know that this is a big topic and there's lots more questions. And we know that we're just scratching the surface. And as you heard from both Melissa and Dr. Murthy, it's important for you to speak to your experts in this area, your clinicians, your EEO office, to find out more that's particular to you. So I appreciate all your questions. We tried to answer many of them. There's clearly much more to be done. Thank you so much to our guests. We want to go to one more poll, or we have a couple more things to do. So if we can get to the poll. So now that you've learned more, how comfortable are you in talking about menopause in the workplace? 1, not at all. 2, slightly. 3, somewhat. 4, fairly. Or 5, completely. Thank you for participating. All right. Well, I'm already seeing our completely comfortable going up above where it was before. With about 65% of you participating. So we got somewhat fairly. Our numbers have shifted. So I thank you for participating, and hopefully with some of the additional resources we share, we will get to feel even more comfortable recognizing that this is a part of our life. So one more poll. We'd like to know if this webinar increased your knowledge of the topic. Yes, no, or unsure.
Deborah, if I may, I do just want to bring out an important point about something that I mentioned earlier about the CEI's citywide equity inclusion. My offer to try to connect an individual who's having problems getting through to their EEO office. That's different. If someone is not happy with their reasonable accommodation decision from their EEO office, that CEI does not have a role in that process. There is an internal appeals process that every agency has. The decision maker is the agency head or their designee. Citywide equity inclusion does not get involved in that specific process. So I just want employees to understand the difference.
Right. Good clarification. Thank you. Yeah, it's not the appeals process. It's just if you're having trouble getting a response.
Yeah.
Right. Or have a question. Okay. Thank you. All right. So 88% of you felt that this added to your knowledge. So thank you so much for sharing that with us. So we hope part of what you walked away from today is that over 50% of city employees will be impacted by menopause, and that it can last between 5 and 10 years. There are a multitude of individual physical and emotional symptoms that can be experienced. We shared a ton here. People raised many more. And there's probably some that we didn't even get to. And we also don't want to make light, because we know there are folks who have even more significant symptoms than what's been shared today. And I don't want to lighten or diminish it. It's very challenging for many. And that there are also multiple treatments for menopause. And that you need to talk to your provider about what's appropriate for you as an individual, given your case history, your family history, your job, your needs, etc. So this is really an individual option. And yes, there isn't as much research or readily available information in the marketplace as there should be. And that's a longer social discussion, political discussion, but we're trying to make a dent in it. And finally, that as employees, we can discuss our symptoms at work, and we should. As Melissa said, don't suffer in silence. That you can work with your EEO officer to see if there is an accommodation or a modification that is available to you. So with that, these are some additional resources that are available. And again, we'll be sending this out with live links, and it will be in the recording. Feel free to share the recording, the links, all of these resources. And I see one of my colleagues says she talks about menopause all the time at work. That's terrific. I thank you so much, Melissa and Amita and Heidi Bear and Anna Tan, who are in the background. It's so helpful. And so WorkWell is continuing to be here for you. So we're in the final days of our flu clinics. If you haven't gotten your flu shot, whether you do it at work or you go to your pharmacy or you go to your provider, it's really important. They're expecting flu to be back with abundance this year. It's also the season of gratitude, and we know that gratitude is an important way for us to be resilient, to help our own mental health, the mental health of those that we're expressing appreciation. We'll have a webinar like this next week on December 7th to kick off our challenge, which next slide will be coming the following week. Gratitude is like a muscle that needs to be worked in order to, again, have that change our own personal mental well-being. And you can have a great impact on those around you. And finally, on December 12th, 20th, we have a webinar called Building Connections and Combating Loneliness. Well, there's all sorts of talk about celebrating the holidays. We also recognize that the holidays could be a very difficult time and could be actually more challenging than any other time of the year. And so through this, there'll be an opportunity to learn how to make connections and how to address it. So we hope that you will join us for one of these sessions. We look forward to continuing to bring programs to you. One of the ways to know or to connect with us is to join our mailing list, and you can use this QR code to join. And then you get to hear about all of our programming upfront and first. So again, I thank you so much for being a part of our tremendous city who does the most extraordinary work in often the most challenging situations. So thank you so much for your service as city employees. We really do appreciate you, and we want to be here to serve you as you serve others. Please stay in touch with us through our various programs, and thank you. Have a wonderful day. Try and stay warm and stay healthy. Thank you all.